This week on the BackTable Podcast.
If a patient comes in 22 years old with EoE, but also have severe asthma and eczema, then if you have to choose topical therapy for the esophagus or a systemic biologic to calm down a type 2 inflammation, then I will pick a type 2 inflammation blocker inhibitors, such as Dupixent, because they will take care of the asthma, eczema, and EoE at the same time and reduce the overall steroid burden. But if someone only have EoE but no other atopic disease, then the option of PPI, topical steroid, and Dupixent are all available. I think the allergist can help the GI to find out if a certain particular option are more beneficial to the patient if there are multiple comorbidities, especially up to 75% of the people with EoE have some atopic disease.
Welcome to BackTable ENT. My name is Dr. Basil Kahwash. I'm a board-certified allergist-immunologist, and I'm the guest host of today's episode. Thank you to the usual hosts, Dr. Gopi Shah and Ashley Egan, for inviting me on to guest host a few episodes of the BackTable ENT show that overlap with both allergic immunologic and ear, nose, and throat conditions. I'm very excited for today's episode about eosinophilic esophagitis, and I could not have asked for a better guest for today's episode, somebody I'm very excited to speak to, Dr. John Leung. Dr. Leung is one of the only, if not the only, dual board-certified allergist-immunologists and gastroenterologists in the United States. And I am super thrilled to have him on our show and really looking forward to talk to him. Dr. Leung, welcome.
Thank you for inviting me.
Can you tell us a little bit about yourself and your career path and how you became both board-certified in these two specialties that are so relevant to the treatment and the workup of eosinophilic esophagitis?
Absolutely. So I started my career as a gastroenterologist, and I do a lot of translational research and basic science research. And I developed an animal model that is in the mice. So you feed the mice eggs, then the mice will develop colitis. So my purpose at that time was to find out how inflammatory bowel disease develop. But it is a very non-specific inflammation, so we try to develop a model that is a food-driven, specific food-driven on and off switch to develop to study the colitis pathway. And at the same time, I find out that the EoE is exactly that disease that is a food-driven specific disease in humans. So it triggered my interest in studying food-related GI inflammation, inflammatory disorder, mucosal immunology. That's how I started my career. And then I find out that why not just do another fellowship to study more and to learn more about allergic pathway and immunological pathway. That's why I finished my second fellowship in clinical and research to study gut-specific food-related GI inflammation.
I like that. I like that approach. Sure, why not just do a second fellowship? So you already mentioned eosinophilic esophagitis, which goes by the acronym EoE very commonly. Can you just explain a concise definition of what is eosinophilic esophagitis? It's obviously something that's been increasingly recognized, and if you could speculate also about why it's getting so much more attention.
You just open a can of worms. I can talk about EoE all day for days and days to no end. So EoE is a disease of the esophagus. It's an immune-driven disease. Is that people develop dysphagia, swallowing difficulties. Sometimes they develop chest pain, abdominal pain, chronic cough, feeding disorder. So it's a disease of the esophagus and infiltrated by eosinophils. So one of the classic features histologically. So these people develop this esophageal symptoms with a lot of eosinophil, very easy to recognize on biopsies. And that is basically the diagnosis and the features of EoE.
So as you know, the majority of our audience for this podcast are ear, nose, and throat physicians, ENT surgeons, and ENT healthcare professionals. So why would you say it's important for them to be familiar with eosinophilic esophagitis also? So, obviously, myself as an allergist, you as both an allergist and a gastroenterologist, we see cases of EoE quite frequently. But what about our ENT colleagues?
Well, ENT is extremely useful because sometimes patients present at ENT first. They have problems swallowing, so they feel that food gets stuck in the throat. They feel a lump in their throat, and they present to ENT first. And then when ENT take a look, they do not see any physical obstructions or strictures. And EoE can only be diagnosed by endoscopies. So it's very important for ENT to recognize that if they don't see any physical strictures or obstructions in the throat, and patient have a throat closing sensations and tightness and swallowing difficulties, and to think about EoE. Another thing is that it's very important that patients with EoE sometimes also have a lot of time also have allergic rhinitis or nasal polyposis, and making a confirm the diagnosis of nasal polyposis, for example, will help us to determine what is the optimum treatment for EoE, because some of the EoE treatment can also take care of nasal polyposis, which we will discuss about the treatment pathway in a bit.
Absolutely. Yeah, we're going to get to management certainly later in the episode. So you kind of alluded to this already, but EoE can present variably with different symptoms. And I think when we look at EoE, we often think of the classic symptoms in the pediatric age group and classic symptoms in adults. So if you could just run through how a pediatric patient with EoE is likely to present, and then also an adult patient with EoE, what are the classic features that are likely to be seen diagnostically?
So for very young infants, they cannot complain, right? They cannot articulate the challenges in swallowing. So we often see feeding difficulties, and they vomit, they have abdominal pain, they have a lot of reflux, they're not gaining weight. And when they get a little bit older, they may be a picky eater. When they're a little bit older, even older in school, sometimes they may even skip lunch. When we ask them, why you skip lunch? Because, I eat so slow, I don't have time to play. That's why I skip lunch. So slow eater. When you get older, teenager and adults, they usually complain, more than 70% or 80% of them complain about solid food swallowing difficulties. So one of the things I learned over the years is that almost all EoE patients complain about solid food dysphagia. So if you see a patient with liquid food dysphagia, you may want to think about more structural obstructions, mechanical obstructions. So when the adults, sometimes they see food impaction. As you know, that EoE is the number one reason for food impaction that you see in the emergency room. They usually drink a lot of fluid in between bites to flush the food down. They chew a lot of food. And one thing about ENT, I have a few patients referred to me by ENT because the patient initially present to the ENT with a TMJ problem, and then the ENT take a very good history, find out the TMJ is due to excessive chewing of food, and refer to us, and then we find out that the patient have EoE, because this is one of the classic symptoms of EoE patient. They chew the food excessively and causing joint problem and other problems. So excessive chewing is one of the symptoms, but adult is solid food dysphagia, and for children it's a little bit more non-specific, feeding disorder, picky eater, right, abdominal discomfort, vomiting.
Yeah. I mean, abdominal discomfort, obviously notoriously thing to sort out in children, but EoE should certainly be on the differential. I'm glad you mentioned food impaction. Also, I remember at one of the large medical centers that I've worked at, gastroenterologists would dread being on call on Thanksgiving night, because that was just so commonly a time when people would come in with food impactions. Is that your experience also?
Absolutely. I think there's a few papers and small abstracts talking about post-Thanksgiving. If food impaction there's a peak there if you look at the trend over the years. I think because of most of the time people eat a lot and then they drink a lot, so they have a food impaction in Thanksgiving night, yeah.
Are there any other questions or history questions that an ENT physician might ask a patient to help distinguish EoE from another cause of dysphagia or another cause of pain, or not only trouble swallowing, but pain with swallowing?
Well, pain with swallowing, right? Of course, think about HIV, candida infection in the esophagus, and also if they're older, you think about achalasia. But ENT has over 75% of the EoE patient have some sort of atopic disease. We call it type 2 inflammation. Gotcha. They may have asthma, eczema, allergic rhinitis, nasal polyposis, eczema, food allergies. So it will be extremely helpful to ask if they have any atopic background, because that may point towards more EoE than other mechanical problem in a young person.
Okay, that's very helpful. And we're going to talk about the endoscopic exam in patients with ENT shortly, in terms of the upper endoscopy that these patients typically undergo, I should say. But what about oropharyngeal or laryngeal physical exam? Are there any findings in those parts of the body where an ENT is more commonly going to look that might suggest EoE?
So first of all, the EoE diagnosis is based on upper endoscopies with the esophageal biopsy. So by examining the throat, sometimes you may see a postnasal drip, maybe due to acid reflux, but you will not be able to diagnose EoE with a routine ENT exam.
Okay. Not with a routine ENT exam, but let's say an ENT is doing a nasal endoscopy or a laryngoscopy, and I know occasionally they take a look in the esophagus also. Is there anything that they might see with that quick look in the esophagus that they might observe without obviously doing the full upper endoscopy of both the proximal and the distal esophagus?
Absolutely. If they take a look at the esophagus, first of all, about maybe 15-20% of the esophagus can look perfectly normal with EoE, but majority of them will have edema. They will have rings in the esophagus. They have furrows, and sometimes you even see strictures of the esophagus. And occasionally, you will see some white dots, so like an exudate, microabscesses of eosinophil in the esophagus. But even if they look normal, about 15% of the cases, they still may have EoE if they present with a solid food dysphagia.
So it sounds like endoscopy is really the mainstay of making the diagnosis of EoE. Is that fair to say?
It's very fair to say, although now we'll talk about in a little bit, there's some new device that we can diagnose or screen for EoE without endoscopies. Yes, but yes, majority of the cases now is diagnosed by endoscopies and with biopsies.
So endoscopy with biopsy, and can you describe for our audience the diagnostic criteria for making EoE? Because it's pretty well defined.
So more than 15 eosinophil per high power field is the definition of EoE. In the past, there is some confusion about, if the eosinophil only in the distal esophagus, do we call it EoE or not? The new guideline and the consensus is that if you see any biopsies showing more than 15 eosinophil per high pi field, then you have EoE. So one thing to pay attention is that we need 6 biopsies of the esophagus at the minimum and 2 different levels to confirm the diagnosis, because EoE is a very patchy disease. If someone just perform like 2 random biopsies in the esophagus, they may miss up to 50% of the cases. So it's very important that the endoscopists now with a lot of educations, now most of the endoscopists know they're supposed to get 6 biopsy in at least 2 different locations, 2 or 3 locations to screen for the disease. So any biopsy more than 15 eosinophil per high power field confirm the diagnosis of EoE.
And patients will often ask us, okay, like you've made this diagnosis, where did these eosinophils come from? And, there's a little bit of difficulty in understanding, I would say sometimes, where it's not strictly speaking a food allergy in the way that we classically think of a food allergy, but at the same time, food does play a role. Can you elaborate a little bit on the pathogenesis of EoE and where the role of food exposure really, where that lies?
That's a very good question. So when I try to explain to my patients that what eosinophil, I tell them that it's a type of white blood cell. They usually involved in allergic reaction. For example, I tell them that for people with eczema, if you look at under the microscope of the skin biopsy, you will see a lot of eosinophil. So eosinophil is involved in allergic diseases. So when they attack the esophagus, then we call it EoE. It's an allergic disease. So the second question is, how is the relationship of food allergies and EoE? In my mind, EoE is a type of food allergies. And I explain to people that you have a food allergy that only affects the esophagus. So it's an isolated food allergy in the esophagus. And most of the time, very often, we can identify exactly what food is causing the allergic reaction. If we can remove the food trigger, then your EoE will disappear on remission. So I tell them that EoE is a type of food allergy, and it affects only the esophagus. That's why skin testing and blood testing and patch testing on the back are not useful. So because the food allergy only affects the esophagus.
Yeah. So really, it sounds like the traditional modes that we have of testing for food allergy that you just mentioned, they don't really have too much of a role in the diagnosis of the specific food triggers for EoE. It's really kind of, to some extent at least, a guessing game where you withdraw the food from the diet and then you observe and see how the patient responds. Is that fair to say?
It's fair to say. So in my practice, we don't do any skin testing, blood testing, or patch testing for food because their predictive value is very modest. So instead, in my protocol, we try to avoid milk and gluten as the first step. By avoiding both food, there's a 65% chance we can clear the esophagus within a few weeks. And if they fail the 2-food elimination diet, then we'll proceed with a 4-food elimination diet. The top 4 food that are affecting EoE is milk, number 1, followed by wheat, soy, and egg. So by avoiding 4 different food, then there's a more than 50% chance the EoE can be under control. So 2 food first, milk and gluten, 65% success rate. If they fail that, we'll expand to 4-food elimination diet. And that is about 50% response to that 4-food elimination diet. And after that, like many experts in the field, we do not do more extensive diet because it will be very difficult and it's not practical. We know that from clinical trial, if you put someone on an amino acid diet, it's almost 100% of the time the EoE will be under control. But it is not practical and it's not sustainable for adult and even pediatric patients.
So it sounds like the gastroenterologist is virtually always going to be the one making the diagnosis of EoE, establishing the diagnosis. When does the gastroenterologist get other specialists involved? For instance, an allergist, obviously in your case, you're both, so you can just consult yourself. But let's say you weren't as a gastroenterologist. When do you involve the allergist? When do you involve the ENT physician potentially? And when would you involve a nutritionist or a dietitian?
So yes, the gastroenterologist will be the one making the diagnosis. And then after that, we have to decide what treatment is the best for the patient. This is how I tell patients the options. Elimination diet, if you pick that, then an allergist specialized in food allergies, elimination diet may be extremely helpful with the help of a dietitian. The second one, we'll be using biologic available, FDA approved, and biologic or topical therapy with topical steroid. So how to choose which medication if the patient wants a medical therapy depends on the comorbidities. So as I said, 75% of the EoE patients have some atopic disease. So I recommend that the GI will refer the patient to allergies and find out to co-manage the 75% of the time. They may have some food allergy, nasal polyposis, asthma. And if they have, for example, if a patient comes in 22 years old with EoE, but also have severe asthma and eczema, then if you have to choose topical therapy for the esophagus or a systemic biologic to calm down a type 2 inflammation, then I will pick a type 2 inflammation blocker inhibitors, such as Dupixent, because that would take care of the asthma, eczema, and EoE at the same time and reduce the overall steroid burden. But if someone only have EoE but no other atopic disease, then the option of PPI, topical steroid, and Dupixent are all available. So I think the allergist can help the GI to find out if a certain particular option are more beneficial to the patient if they have multiple comorbidities, especially up to 75% of the people with EoE have some atopic disease.
And what about the nutritionist or the ENT? Is there ever a time where you're going to refer directly to ENT, a patient with EoE, or is it more so that they're the ones referring to you because they see a patient for dysphagia and they suspect that the patient is likely to have EoE?
Wow. For number one, for acute emergency, if the food is impacted very high up in the esophagus, we call ENT to help. Panically, at the middle of the night, ENT will come in to help us with the more upper impactions. And number two, if we see a lot of strictures in the upper esophagus, we will talk about dilation in a bit, but if the stricture is very high up on the esophagus, I almost always call ENT to help me to dilate if it's very high up in the esophagus. GI is very comfortable dilating middle or distal esophagus, but if it's very high up, I usually call ENT. So ENT play a very important role in terms of helping with the proximal esophagus dilations for emergency food impaction if it's high up in the throat. And they can also help me to diagnose nasal polyposis. Then they can also, that diagnosis by itself can also affect my choices in terms of taking topical therapy for the esophagus or something like a biologic that can also take care of nasal polyposis. So ENT play a very important role in this. And dietitian is important. I will give you an example. let's say that I put a patient on a milk-free and gluten-free diet. So, and the first question the patient may have is, hey, is gluten the same as wheat? Is avoiding wheat alone is enough? So this sounds like a very simple question, but unless you're in the field, understand what gluten and wheat, the differences are, may be challenging to some. So a dietitian specially trained in allergies may be able to help, because gluten is basically wheat, rye, and barley. So if you have to avoid gluten, then you're avoiding both wheat, barley, and rye. But for EoE, technically, you only have to avoid wheat because majority of the EoE is due to wheat, but not rye or barley. But at the same time, the dietitian will tell you, look, gluten-free is so much easier because very few people eat barley and rye. Most of the culture do not consume a lot of them. And with a green big sign saying gluten-free is also very easy for the patient to learn. So stuff like this will be very helpful to a dietitian to guide you through all the specific about elimination diet.
I want to quickly pivot back to the role of the allergist because I'm biased towards allergists before we move on to treatment. But I think one thing we should address is the role of allergy skin testing for environmental allergens.
Oh, yes.
Because you did mention that skin testing for food allergens is generally not indicated unless there's a highly suggestive history of allergy to a food, or I should say anaphylaxis to that food. But environmental allergy testing, I have seen some evidence that suggests that there's a role for that in the work of patients with EoE who, as you mentioned, many of them have allergic rhinitis coexistent as well. So can you elaborate on that?
Oh, yes. So if patients have allergic rhinitis, like 45% of the EoE patients, I will strongly encourage them to undergo immunotherapy to get rid of the environmental allergies. So allergy shots, we call it, or subcutaneous immunotherapy, is extremely effective in getting rid of seasonal allergies. And there are a study to show that sometimes dust mites, pollens, cockroach allergens, or mold can trigger EoE symptoms. Although the majority of the inflammation in my mind is due to food allergies, but there's a small component of environmental allergens can flare up a subset of patients with EoE. So in my mind, if they have a lot of sinusitis, allergic rhinitis, why not, if they have EoE, why not just get rid of their environmental allergies, the aero allergens, and see if they can also improve both the nose, the lung for asthma, and potentially the eczema too, right? As you know that by getting rid of the dust mite allergy, you can also improve the eczema situation. So yes, the answer is yes. I always, if they have any symptoms of seasonal allergies, or asthma, I send them to an allergist, do all the testing, and strongly recommend immunotherapy to get rid of the underlying allergies to aero allergens.
Yeah, and I couldn't agree more. I mean, to me, it's an example of how the immune system is so tightly woven together that when you address allergic rhinitis, you're also helping the patient with their various other atopic comorbidities, including EoE if they have EoE. So yes, I think it's an important thing to highlight. If these patients haven't been tested for environmental allergies and they suspect that they might have them, that's really something that needs to be addressed alongside directly addressing the EoE. But as we talk about directly addressing the EoE, you've talked about various modalities of treatment for EoE, including dietary avoidance. I think we've covered that pretty well today, but I would like to talk a little bit more about the management of EoE with pharmacology before we talk about the management of EoE, through things like management of EoE morbidity and dilations and things like that. But let's start with pharmacology. So, as you are approaching a patient with EoE and you're thinking about medically how you want to treat them, tell me about what that looks like in your mind.
So there are 2 FDA-approved medications for EoE, and there's one medication that's not approved by the FDA. So one of those that are not approved by the FDA, but is on the guideline for treatment, and it's very common practice, is PPI. So we learned that PPI can block the eotoxin 3 production from the epithelial cell from the esophagus. So by taking high-dose PPI, usually 20 milligram of omeprazole twice a day, for example, can actually block the eosinophil getting into the esophagus. So
did your lab learn that? Did that discovery come from you?
No. I hope that I'm that smart. So
your lab does some great things, but yeah, I thought it, not beyond the realm of possibility. But yeah, sorry, please go on.
So 50% of the time, I tell people that if you put someone on a PPI high dose, 50% of the time, you'll clear the esophagus. However, there is some controversy about the increased risk of dementia due to PPI, and it only works 50% of the time. So we always discuss other medical therapy that is approved by the FDA. So the second medication approved by the FDA for short-term use for 12 weeks is called budesonide, a slurry. It's called EoE. Basically, it's a topical steroid that you can swallow. It's a slurry. So you take it twice a day. It works about 65% of the time in clearing the eosinophil from the esophagus. And we have been using budesonide almost for 10, 15 years now, off-label, until there's a product called EoE that is approved by the FDA recently. So it's a very good option if there's no other reason or no other type 2 inflammation in the body. The third type, the second medication that is approved by the FDA for short-term and long-term use will be Dupixent. Dupixent have multiple indications for nasal polyposis, for example, for eczema, for chronic hives, for asthma, and also for EoE down to 1 year old. So Dupixent block the production, block IL-4 and IL-13 pathway. And in clinical trial, it showed that at least 85% of efficacy, it can clear the esophagus of eosinophil. So those are the three major medical therapy that is available for patients now. Once again, is the PPI, which is non-FDA approved, about 50% effectiveness. Second one is topical steroid called budesonide, slurry twice a day, 65% plus effectiveness. And a biologic once a week called Dupixent that block IL-4 and IL-13 with multiple Th2 inflammation indications by the FDA. It works at least 85% of the time.
Yeah, and it's convenient that for our ENT listeners, those are all treatments that they're familiar with and very familiar with in the conditions that they treat, whether it's PPI, whether it's topical budesonide. Obviously, the topical budesonide is applied in a different location. And then dupilumab or Dupixent, which, as you indicated, is also used in the management of nasal polyp disease. So is that the sequence of treatments that you use in your patients? Is it essentially the patient comes in, you try PPI, if they fail that, you try the swallow budesonide, and if they fail that, you will put them on the biologic, the dupilumab?
Yeah, so first of all, I always try to use PPI first because PPI is very low cost, widely available. I tell the patient that the other options are very good too, but they're very expensive and no one can guarantee that they have insurance for all the time. So we need to develop a backup plan or a plan in case there's no insurance available. So PPI is over the counter, very accessible, have a long safety track record. So I always try PPI first. If they fail or if they don't want to continue on long-term PPI because of side effects and other concern, then I will present them with the other two options. So how do I pick the other two options? Depends on the comorbidities. If someone have many or few type 2 inflammation such as eczema, asthma, nasal polyposis, chronic hives, then I may choose to do biologic because it can FDA approved for multiple indications. But if they only have EoE but no other type 2 inflammation or a patient is afraid of needles, needle phobia, then we may choose an oral option such as budesonide oral.
Okay. Before we talk about the complications of EoE, I'd like you to weigh in on the emerging therapies for EoE. Is there anything that you have your eye on in terms of a potential new treatment for EoE that's coming down the pipeline, or at least a broad category of treatments that we might be looking at and using in our EoE patients?
Yes, as you know that Dupixent is once a week for EoE, so we are hoping that in the future there will be...
In adults, to be clear. It's once a week in adults. Yeah, as you and I have discussed before. In kid patients, it's different.
In kids patients every 2 weeks, so it depends on the weight, you're right.
Right.
So we are hoping that there will be a medication that you can stretch out a little bit, maybe once a month or once every 3 months. So there are a few candidates that is undergoing a clinical trial, such as anti-TSLP is a very active pathway that people are looking at. Anti-IL-13 has been studied, have shown a pretty good result, but it's not in the market yet. There is also anti-mast cell therapy is also under active research and the data is not out yet. So there are a lot of potential therapy that can be done once a month or once every 3 months being studied and potentially come to the market.
Yeah, those are all things that I'm keeping an eye on also. Well, let's talk about the risk of developing complications of EoE. You've mentioned some of those complications already. So we're talking about things like esophageal strictures, esophageal webs, or really significant narrowing fibrosis of the esophagus. What's the overall risk of progression to that? And who do you tend to see those complications in?
So not everyone will develop very bad strictures. So now there are, at least in research, and they may become commercially available very soon, that we can predict the phenotype, so-called phenotype of EoE. We know that some of the EoE phenotype is more aggressive, forming fibrosis, and some of them are less aggressive in developing fibrosis. For example, I have a patient that I take care of many, many years. They have EoE for over 20, 30 years, but there's no strictures, and they do not take any medications, and we don't see strictures. And I also see the other spectrum. I have 22 years old, have a 9 mm esophagus, have a severe strictures without therapy. So I think that I am hoping that in the future, this kind of technology will be widely available for our patients to determine the prognosis, whether they have the more aggressive fibrosis type, so we can introduce more aggressive therapy early on. So yes, fibrosis is a very high risk in majority of the individuals. I would say that over a decade, maybe 80% of the individual will have some strictures if you don't take care of the esophagus. I tell people that it may not be tomorrow, it may not be next year, but with time, majority of the cases, if you don't take care of it now, can develop strictures and permanent esophageal strictures and dysfunction.
So when do you dilate the esophagus in patients with EoE? When is that indicated?
I used to dilate very often 5-10 years ago, but for the last few years, I maybe dilate once every 2-3 months. So with the modern therapy, if you can eradicate the inflammation by any of the therapy, effective therapy, I learned that the esophagus will dilate itself over time. So let's say that a patient come in, for example, with a diameters of the esophagus of 14 mm. If I put them on an effective therapy, I would not be surprised a year later, it can be 16 to 18 mm without mechanical dilation. So my approach to this problem may be a little bit different than other experts. I'm not too aggressive on dilation because I know that with time, they will get better. But I dilate patients more aggressively. If the patient is very symptomatic, losing weight, then I may do it sooner. But otherwise, I tell the patient that just wait for a few months, 4 to 6 months, and most of the time with effective therapy, your esophagus will become bigger by itself without dilation.
I mean, it sounds like what you're saying is that EoE is fundamentally an inflammatory disease, not necessarily a progressively fibrotic disease in and of itself. And over time, as we've developed new tools, we've gotten a lot better at controlling the inflammation. And we, in your experience at least, inflammation control can actually reverse fibrosis once it's set in, not only prevent it from happening. Yeah, is that fair to say?
It's very fair to say. In GI, people know that the cirrhosis or even fibrosis in the liver can reverse if you take care of the inflammation. The idea is the same.
Yeah. But the liver is a regenerative organ, though, right? The esophagus is, we don't think of it as such, at least.
Until now. So we know that it's slowly.
Now, okay.
Yeah, the body reabsorbs some of the scar and the esophagus will dilate by itself, become more flexible. So it's a good. So we just have to control the inflammation early on if possible.
Okay. Very nice. What about the risks of dilation? Let's quickly touch on that. Are you hesitant to dilate in some patients because there is a risk of a complication from that procedure?
So large-scale studies have been published that the risk of dilation in people with EoE is not higher than the risk of dilation in other non-EoE patients. So in my practice, when I dilate EoE patients, number one, I will wait a little bit to see if it actually can reverse the process itself, the esophagus. In patients that we have to dilate because of severe symptoms, I usually dilate 1 mm at a time. So instead of very aggressively dilate the esophagus very quickly, I try to do 1 mm at a time. And this is the common practice among the EoE provider.
Well, I think that's all really promising, actually, that, dilation is not too much riskier in EoE patients than in non-EoE patients, and that dilation seems to be something that is becoming less frequently indicated in our EoE patients. Before we talk a little bit more about just the long-term future directions of what we're going to learn about EoE, I want to talk, as always, about lifestyle modifications or supportive therapies that somebody with EoE might pursue outside of pharmacology and outside of seeing the GI doctor for follow-up. So can you touch on the lifestyle management as well?
Yeah, a lot of my patients with EoE, because they have it for a long time, they have food aversion sometimes, so they need to see a psychologist. They're always afraid to eat in public because they are concerned that they will embarrass themselves, food gets stuck. So especially younger individuals, one example that I bring up early is that there are young kids with EoE, sometimes they skip lunch because they don't want to eat in front of others and they don't have enough time to eat. So and my experience is that even if you reverse the esophagus diameters and eliminate the inflammation, the symptoms get better, but they're still afraid to eat. So they still chew the food excessively. So that kind of behavioral changes, a psychologist or therapists experience in food aversions can actually help in behavioral.
Yeah, that's very helpful, obviously. And, so much of what a patient might report, if they've lived with something for a long time, it becomes really hard to distinguish between what is really pathology-based versus what is more psychology or fear-based, the risk of provoking the same symptoms or a traumatic episode that they've had occurring again in the future. So yeah, I think you've touched on a really important point there. I want to talk about follow-up endoscopies. So you talked about the initial diagnosis, the initial diagnosis of EoE is made based on an initial endoscopy that reveals eosinophils in the esophagus. In your practice now, how often does a patient need to go back for a follow-up endoscopy and repeat biopsies?
This is a very controversial topic. So in the guideline, they also touch upon it. So a lot of experts in the field believe that even in stable EoE, 1 to 3 years, they should get a follow-up endoscopies for surveillance. So in my practice, I don't do it. So let's say that a patient on a meal-free elimination diet and has been successful, and we put the EoE on remission, and the patient does not develop any new symptoms. For those patients, I tell them, look, if you want me to take a look, we can take a look from time to time, but I don't think it's medically necessary unless you have symptoms develop. For example, another patient that has been stably controlled with Dupixent, and since that there's no case report of developing refractory resistance to Dupixent or clinically meaningful antibodies to Dupixent, then I tell them that if you have no new symptoms while you're on Dupixent, I do not have to scope you again. So my approach is a little bit more conservative. I don't scope patients on stable therapy, effective therapy, unless they have new symptoms. But that is not shared by a lot of endoscopists. I think most endoscopists like to surveillance every 1 to 3 years. And as you know that EoE have no risk of developing cancer. Unlike acid reflux, have Barrett's, they may need surveillance. EoE has not been associated with esophageal cancer. So something to keep in mind, and maybe we can do a decision sharing with the patients, tell them the facts, the statistics, and see what they want to do, and we can make a decision together. But in my practice, I make it very clear, unless you have new symptoms, I do not recommend a repeat endoscopies.
Yeah, I mean, you made two really important points there. First of all, that EoE does not progress to malignancy, so we don't perform endoscopic surveillance in order to monitor for the development of something like an esophageal cancer, which would be obviously quite a devastating, life-changing diagnosis. And then, of course, your point about not necessarily having a strict guideline for endoscopy surveillance in your patients with EoE that are on long-term treatment and they're doing well. I'm sure your patients really appreciate that, the fact that you're sparing them from having to undergo sedation and have to put themselves through this endoscopy so often.
Right.
I want to just, as we're wrapping up the episode today, quick bullet points. What information is the most important that has to be communicated between allergy, GI, and ENT teams or clinics that are managing patients with EoE? If you could summarize 1 point for each.
Of course. So I think that the most important is communication, as you point out. So ENT, so what is your plan? Do you plan to have surgery? Do you have a plan for the nasal polyposis, the timing of biologics? So I think that it's very important that for the expert, for the specialist to talk together about the optimum therapy that may benefit multiple conditions across EoE, maybe they have polyposis, they may have asthma managed by the allergist. I think the most key point is that a communication to tell each other what is the diagnosis and what are the options, and maybe there's a collaborative kind of medication that can take care of all the conditions at the same time. I think that is one of the most important points, so that the allergist will not put the patient on a topical steroid for eczema, the EoE on a topical steroid for the esophagus, and then the ENT put nasal rinse with the budesonide on the sinusitis. We don't want that.
Yeah, that sounds like quite a lot of steroid, and that starts to add up, of course, even can be systemically absorbed, and you run into complications from that as well. As we look ahead to the future of EoE management, we've really come a long way already, I would say, within the last decade or so. I'd like you to talk about some of the promising new diagnostic tools and the biomarkers that are on the horizon for both the surveillance and the diagnosis of EoE.
I'll do you one better, man. I will talk about the major challenge in EoE and how the new technology may help to reverse that. So number one challenge in EoE is the delay of diagnosis. Because if you delay the diagnosis more, then more strictures, take longer time for the fibrosis to go away with effective therapy, and the longer patient have suffer. So there are technology available. For example, there's something called a string test, EnteroTrack. Basically, you can swallow a string into the esophagus and you tape the string on your face. You keep the string in the esophagus for about 1 hour, and then you pull it out, and then you send it to the lab. And then the lab will come back with a report whether the patient have an active EoE or inactive EoE with over 90% accuracy. So we can skip the biopsies and endoscopies, because that may be the gatekeeper, that may delay the bottleneck to the delay of the diagnosis. So in the future, my dream will be that PCP, ENT, allergists who doesn't have access to scope can do this kind of a screening test, whether it is an EnteroTrack available now or blood test or saliva test may be available in the future. A widely accessible, inexpensive test that people can screen for EoE for dysphagia in PCP clinic, in urgent care, in emergency room, so we can shorten the duration of delay. That will be my dream for the future, for the near future. Non-invasive monitoring is also very useful, because patient may have to go through PPI, topical steroid, and Dupixent to see which one work, or elimination diet. Any non-invasive step, such as blood work, saliva tests, poop tests, or string tests, may be extremely useful to reduce the cost and the barrier to care, because it's very expensive to do endoscopy and biopsy. So anything non-invasive, inexpensive will be very helpful to advance the field. In terms of medication, the less frequent the medication, the better, because elimination diet, even though it is very effective 65% of the time, but it compromises quality of life. What if I tell you you cannot eat ice cream again for the rest of your life? To me, it's a death sentence.
It's tough to adhere to. Yep.
It's worse than the EoE.
Yeah.
So I'm hoping that we can correct the underlying defect in the immune system, but with medication that have minimal side effects and very long duration and inexpensive. That will be the future.
I want to ask a follow-up question about the esophageal string test, because that's currently something that is available. And is that something that, you alluded to it as a tool for the diagnosis of EoE, and I know that that's something that's being investigated. Are you currently using it as a tool for the surveillance of EoE in lieu of bringing the patient back for endoscopy? If you know they have EoE, have them do the string test in your office. It's 1 hour, and you get an answer as to how inflamed their esophagus is with eosinophils currently.
Absolutely. So in my practice, I use it for screening. If someone came in with acid reflux refractory, have a possibility of EoE, so I may do a string test to find out if the refractory GERD is just due to refractory GERD itself or due to EoE. So I use it as a screening test. It's quick, in the office, real time. And also, I use it for monitoring of disease and responsive therapy. If I put a patient on established EoE with a new therapy, I'll use the strain test to find out if the therapy is effective or not. So I use that for both, for screening and for monitoring.
But just to be clear, when you use it for screening, you will still then, if they screen positive, you will still do a diagnostic endoscopy, correct?
Absolutely. For multiple reasons, I want to see the severity of the disease. I want to see if there's any strictures causing the severe dysphagia. And I also want to see the exact number of eosinophil, because a lot of biologic or topical therapy for EoE require a histological evidence of EoE. So I still have to do an endoscopy for insurance, medication coverage, and also to assess the severity of the disease to give the patient some prognostic idea.
Well, John, this has been a great conversation. I think we've covered a lot of territory in the conversation around EoE, and hopefully this diagnosis is less of a black box to other allergists and gastroenterologists, and of course to our ENT colleagues whose party we have successfully crashed as two doctors with 3 subspecialty board certifications between us, none of which are in the world of otolaryngology. So thanks to the host for letting us interrupt your usual programming. Any final comments before we wrap up the show?
I want to thank you for doing such an important work. So then I always think that the collaboration between specialties is so important to share knowledge, and you provide a platform to do so. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Legretio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.